This conference will now be recorded.
Good morning, everyone. Today's class will be about parathyroid glands. Parathyroid glands. These parathyroid glands are small, tiny 30 to 40 mg weighing glands which are embedded or behind the body of thyroid gland. Okay, am I audible to everyone? Is it audible to everyone?
Yes, sir.
Okay, thank you. So, um, the blood supply of this parathyroid glands comes from the inferior thyroid artery. Inferior thyroid artery. This inferior thyroid artery also supplies the lower pole of thyroid. So, while performing a thyroidectomy, we have to ligate certain structures, and among these are the vasculature. Of the vasculature, the two main vasculature recorded. Of the two vasculatures, the important vasculatures are superior thyroid and inferior thyroid arteries. While ligating the inferior thyroid arteries, you have to ligate it close to the gland. Previously, they used to ligate away from the gland. What happens when we ligate away from the gland? If you ligate away from the gland, the blood supply to the parathyroids are also cut, and this leads to hypoparathyroidism. This ligation is not a problem if this is a hemithyroidectomy, but if in case of a total thyroidectomy, if you ligate both the inferior thyroids far away from the gland, you might damage the blood supply to the parathyroid glands. So be cautious to ligate it close to the glands. What is the function? The function of the parathyroid glands is to secrete parathormone. Parathormone, it helps in maintaining the calcium levels in the body. It maintains calcium levels in the body. The normal calcium count is 8 to 10 milligrams per deciliter. 8 to 10 milligrams per deciliter. Contrary to this, there is something called calcitonin. Calcitonin is nothing but another hormone which decreases calcium. Parathormone increases calcium. Calcitonin decreases calcium. Calcitonin is secreted by parafollicular C cells, which are present in the upper lobes of thyroid. Parafollicular C cells are present in the upper lobes of thyroid. This is how the thyroid and parathyroid maintain the calcium homeostasis. One, there is parathyroid increases calcium levels, calcitonin from the thyroid decreases the calcium levels. Okay, and coming to the position and number. The position and the number of parathyroid glands vary between 2 to 6. The most common being 4. Most commonly 4 glands are present, but the number can vary between 2 to 6. And in terms of position, the superior parathyroid is posterior to the recurrent laryngeal nerve, whereas inferior parathyroid is anterior to the recurrent laryngeal nerve. Remember this: superior is posterior and inferior is anterior. And the position of superior parathyroid can extend from base of neck base till posterior mediastinum, whereas the inferior glands extends from neck till anterior mediastinum. Okay, the inferior lies in the anterior, may lie in the anterior mediastinum, and the posterior may lie in the posterior mediastinum. The superior lies in the posterior, may lie in the posterior mediastinum, and the inferior may lie in the anterior mediastinum. This is fixed. You have to remember this. This is fixed. Inferior is anterior and may lie in the anterior mediastinum, and superior is posterior to recurrent laryngeal nerve and lies in the posterior mediastinum and may lie in the posterior mediastinum. And the reason it may lie in the and the reason inferior parathyroid glands is lies third below the superior parathyroid is because both inferior parathyroid glands and thymus arise from the third pharyngeal arch, whereas superior arises from the fourth pharyngeal arch. But by virtue of thymus, it forms the neck and descends into the anterior mediastinum. While descending into the anterior mediastinum, it pulls off the inferior parathyroid glands with it. That is why, though the inferior parathyroid glands arise from the third arch, and anatomically it should be in the above the superior glands, and but it lies inferior because it descends down along with the thymus. Okay, the inferior glands are inferior to superior because it is descended with the thymus. Okay, this is in brief the anatomy and physiology of parathyroid glands. And another thing is the parathormone, the half-life is 2 to 3 minutes. The parathormone half-life is 2 to 3 minutes. And if you want to assess for parathormone, it should be done then and there itself. Because if you send the sample for any investigation, by the time the sample is the laboratory, it may go off, it may expire off because its half-life is just 2 to 3 minutes. Half-life is 2 to 3 minutes. This maintains calcium as well as phosphate levels. And this, if the calcium and phosphate levels are not maintained, there is a wide range of disorders affecting muscular system, nervous system, and the skeletal system. All the systems will be affected. When the blood has low calcium levels or increased phosphate levels, it is signaled to the parathyroids, which releases parathormone. And this parathormone, it breaks down the calcium from the bone, and it increases absorption of calcium from the kidneys as well as the intestines. Increases absorption of calcium from kidneys as well as the intestines, and all these three contribute to the increased calcium levels. And when the calcium levels are increased, it sends a feedback mechanism and decreases the parathormone levels. Okay, and we see two types of disorders arising from the parathormone. One is hyperparathyroidism and the other is hypoparathyroidism. Parathyroidism is where the parathormone is released in excess, and there are three types of it. One is primary, one is secondary, and the other is tertiary. Primary, secondary, and tertiary. And this other entity called pseudo hyperparathyroidism and pseudo hyperparathyroidism. Okay, one is pseudo hyperparathyroidism and other is pseudo hyperparathyroidism. Double pseudo. Whatever the type of hyperparathyroidism, the symptoms are usually the same. They may be mild to severe, and mostly they are non-specific. They may be mild to severe, and they may be mostly non-specific. And the signs and symptoms that we see are: one is, as the increased calcium, increased parathormone leads to excess of calcium absorption from the bone. The bones will become fragile and will fracture easily, and this is osteoporosis. And the clinical way to identify this condition is subperiosteal and subperichondral loss osteoporosis, which is seen on x-rays. And due to increased calcium, there is excess precipitation within the renal calyces, leading to stone formation. And any electrolyte in excess favors diuresis, so there will be increased urination. And I forgot to tell you the symptoms of the parathyroidism has something called has a mnemonic, which is called as moans, groans, excess overtones, and groans. That is, the patient will have abdominal pain, so he will moan continuously due to pain, and there will be stones. Okay, and there is excess overtones, that is due to excess calcium the muscle will be in a spasmodic or spastic state, that is excess overtones, and the patient will tire easily and there will be weakness. The patient might have depression. He will have continuous bone and joint pains, and there will be nausea, vomiting, and loss of appetite. Coming to the etiology, hyperparathyroidism. In primary, the causes will be parathyroid hyperplasia, that is increase in number of cells within the parathyroid gland, and other is parathyroid adenoma, that is tumorous growth in benign tumorous growth in one or all of the parathyroid glands, and the other is parathyroid carcinoma. Coming to secondary, secondaries, due to some other cause, the parathyroid hyperplasia will happen. That is due to decreased calcium. And the third type is tertiary, autonomous tertiary. Tertiary is because even if the primary and secondary causes are corrected, still hyperparathyroidism is presented. Such a condition is tertiary. Such a condition is tertiary hyperparathyroidism, and what we see is an autonomous nodule on top of hyperplasia. There is an autonomous nodule along with hyperplasia. And the most common cause of primary hyperparathyroidism, is parathyroid adenoma. Then it is parathyroid hyperplasia, and the least common cause is parathyroid carcinoma. And this biochemically, these patients will have high serum calcium and low serum phosphate levels, and there will be low serum phosphate levels. As I've told you, on X-rays, you might see subparietal resorption of phalanges of the index and middle fingers. This is what you see. You can see the bone being eaten off in the tip of the fingers. Coming to secondary. Secondary is not, and other causes of primary. There is something called MEN syndrome. Multiple endocrine neoplasia. Multiple endocrinal neoplasia. In this, MEN1 and MEN2A are associated with hyperparathyroidism. MEN1 and MEN2A are associated with hyperparathyroidism. Of this, in MEN1 there is diffuse parathyroid hyperplasia. In MEN2A also there is mostly a single nodular hyperparathyroidism. And other causes of primary hyperparathyroidism are excess lithium. Lithium is a drug which is used in bipolar disorders. And secondary, when the body has conditions which leads to decreased calcium, and this decreased calcium cannot be corrected, then the parathyroids will again undergo hyperplasia, leading to something called as secondary hyperparathyroidism. And the usual conditions that are associated with such a pathology are renal failure, intestinal malabsorption syndrome, and decreased vitamin D production. All these conditions, unless until you correct the main cause, you cannot correct the hyperparathyroidism. Coming to tertiary, even after correcting this, as I have told you, even after correcting the primary and secondary causes, even and the hyperparathyroidism persists. This slide is wrong. It is hyperparathyroidism. Even after correcting, if the hyperplasia still persists, it is a tertiary hyperparathyroidism. That is example. In renal failure, even after you do a renal transplant, the calcium levels have not normalized, and there which leads to hyperplasia of parathyroid, and leading to so called the tertiary hyperparathyroidism. Despite correcting the problem, if hyperparathyroidism persists, it is called tertiary hyperparathyroidism. Example is post-renal transplant. And coming to the radiographic findings, we can see, as I told you, there is subperiosteal bone resorption, osteoporotic changes, ground glass appearance of the jaw, ground glass appearance of the jaw. So you can see there is decreased bony, there is decreased bony opacity, giving to something called as a ground glass appearance. And diagnosis is mostly because of symptoms and serum calcium. As I have told you, serum parathyroid, you cannot it need to be present at the laboratory at that time, and immediately the test must be assessed, or else it will expire. The parathormone will expire because of the low half-life. And the gold standard for diagnosis is um, immunoassay, that is, it is given as wrong. The gold standard for diagnosis is exploration, is bilateral neck exploration. The gold standard for diagnosis is bilateral neck exploration. That is, you need to go for a surgery to see for hyperparathyroid glands. You see for hyperparathyroid glands, you need to go for bilateral neck exploration. That is gold standard. And the excuse me, and the routine test that you have to do is the serum calcium levels and X-rays. Any conditions which is associated with increased bony resorption, there is increased alkaline phosphatase levels. This increase, example metastatic bony lesions, there will be increased alkaline phosphatase. Similarly, when there is destruction of bone here, and so there will be increased alkaline phosphatase levels. And these are the various dental abnormalities, loss of odontin, something and everything, loosening of teeth, falling of teeth, floating teeth, and so on. And there is something on brown tumor. Brown tumor is nothing but as the bone weakens, there will be formation of a cystic swelling. As the bone weakens, there will be formation of cystic swelling at the mandible, and such tumor is a brown tumor. Okay. Okay. So for all these conditions, for all the causes of hyperparathyroidism, the one and only treatment is parathyroidectomy. The one and only treatment is parathyroidectomy. So, as I told you, the gold standard for diagnosis of hyperparathyroidism is bilateral neck exploration. But then and there, the patient may or may not be fit for surgery. So, you need to look for alternative diagnosis. So, then comes the radiological diagnosis. You can go for an ultrasound examination. Ultrasound examination may not always be correct because it is examiner dependent. Then the best investigation of choice will be as it is a soft tissue swelling, CCT might not be of much use. So for any soft tissue swelling, remember that you need to, the better way is to go for an MRI of the neck, MRI of the neck. And further increasing sensitivity, you can use something called a SPECT, single photon emission computed tomography, SPECT. It's a type of CT. It is a type of CT which uses single photon emissions, SPECT. And there is something called Technetium 99 system EB scan. Technetium 99 system EB scan. This technetium 99 is a contrast medium which is specifically and which is tagged to system EB, and this system EB is specifically absorbed by the parathyroid and adrenal glands. And as you are imaging only the neck part, the hyperparathyroid glands only will be elaborated. Okay, so if the patient is not fit for surgery, the better ways to diagnose such a conditions is ultrasound scan, which is not much sensitive, and the best sensitive investigation will be technetium 99 system AB scan, technetium 99 system AB scan, and SPECT scan. Okay, and after you have made a diagnosis, you need to work upon the patient, the routine investigations and localizations and so on. And the treatment for all these three kinds of hyperparathyroidism is parathyroidectomy. Parathyroidectomy. Okay. If it is a parathyroid adenoma, usually it is single. Parathyroid adenomas are usually single. So single gland exploration and remaining gland you can just evaluate, and single gland surgery is sufficient. But if it is a parathyroid hyperplasia is usually involves all the four glands. Usually involves all the four glands. Okay, remember this. Parathyroid adenoma most commonly is single, but parathyroid hyperplasia may involve all the four glands. So, in parathyroid adenoma, the treatment is single gland excision, whereas parathyroid hyperplasia is you need to remove all the four glands. But excision of all the four glands will put the patient at a risk of hypocalcemia. So it is then comes a new surgery called the 3.5 surgery. 3.5 surgery. All the three glands and half of a normal looking gland is excised, and the remaining the half gland is cut off into pieces. The remaining half gland is cut off into pieces and implanted in the sternocleidomastoid, ipsilateral sternocleidomastoid. The gland, if you save the left gland, you make it into pieces and implant into the left sternocleidomastoid. Implant to the left sternocleidomastoid or to the left forearm in the brachioradialis muscle. The brachioradialis muscle. Remember this: sternocleidomastoid and the brachioradialis muscle. And wherever you implant this glands, you need to tie a stitch, non-absorbable stitch, because in future, if you see any pathology in this saved gland, you must be able to identify. That is why you need to apply a stitch wherever you implant the gland. Okay, this is 3.5 parathyroidectomy. And if it is a malignancy, you need to remove all the four glands, okay, along with the thyroid gland. Okay, you need to do a total parathyroidectomy, along with, if only one side has carcinoma, you can just do a hemithyroidectomy, or if there is both sides, you have to do a total thyroidectomy, and along with regional lymph node dissection. Okay, if it is a carcinoma, you go for total parathyroidectomy along with total thyroidectomy with regional lymph node dissection. Okay, so this is the treatment for hyperparathyroidism. If it is adenoma, single gland excision; hyperplasia, 3.5 surgery; and if malignancy, total thyroidectomy, and regional lymph node dissection. Okay, so this is hyperparathyroidism. And if the cause is lithium, you need to stop the drug. Also, you should do surgery. If the cause is lithium, you should stop lithium, and also you should do surgery. Okay, because in all the cases you cannot stop lithium, because the patient usually is a bipolar disorder patient. If you stop lithium, the disease will relapse. Okay, the patient will have relapses of bipolar disorder. That is why it's better to go for a surgery in these patients. And the various modes of surgery are open surgery, where you give an incision from if one side of sternocleidomastoid to other side, and you explore beneath the inferior poles of thyroid gland. And there is something called video assisted surgery. Video assisted surgery. This video assisted surgery is usually done for an ipsilateral pathology. For an ipsilateral pathology, video assisted surgeries. Okay. And to see if you have removed all the four parathyroid glands, you need to confirm. The problem with parathyroid is that the parathyroid gland looks exactly as a small globule of fat. Parathyroid gland looks exactly like a small globule of fat. How do you differentiate between these two? Okay, how do you differentiate between these two? And you need to know this because if you are doing a thyroid surgery and you have to dissect around it, you might have to remove some certain amount of fat in that region. And if accidentally, if you remove the parathyroid, you actually if you remove the parathyroid, you need not discard it off. That's the best thing about parathyroid. If you remove the parathyroid, you can reimplant it again at the other place. So to distinguish between parathyroid and fat globule, the best test is you drop the fat globule or parathyroid into a small bowl of water. If it is fat, as fat is oil, this fat will float on water, so it is not parathyroid. And if it is a parathyroid, it will sink to the bottom. Okay, then if it sinks to the bottom, you take the gland, again cut off into pieces, implant in brachioradialis or in the sternocleidomastoid. Okay, so this is how you identify distinguish between a fat and parathyroid. Okay, and and to confirm that you have removed all the four glands, you can do something called you can aspirate blood from the brachial arm, and you can aspirate blood from the carotid arm, and you compare the levels of parathormone between these two. Okay, if the ratio has consistently fallen down, you can confirm that you have removed all the four glands. You have confirmed that you can remove all the four glands. Okay, this is how you perform a parathyroid surgery. And to conclude this hyperparathyroidism, and the other condition where you will do a total parathyroidectomy is when you resect the thymus. When you resect thymus, why should you resect parathyroid when you resect thymus? Because as I have told you, the inferior parathyroid glands have the common origin with thymus. So these inferior parathyroid glands may contain small amounts of thymus. They may contain small amounts of thymus. That is why you need to remove these parathyroid glands along with thymus. Okay, as I mentioned prior, this is a system UV scan. You can identify two structures that are glowing. One is the inferior structure. This inferior structure, this is the adrenal gland, and this is the parathyroid gland. Okay, the black arrow is marking at the inferior parathyroid gland. And this is 4D CT, 4-dimensional CT. This is the parathyroid. And this is an ultrasound image. And also the backlog with the ultrasound is that it cannot scan the parathyroids which are in the mediastinum, And this is an angiogram where the inferior thyroid artery is delineated. You can see a blush. You can see a blush here. These blushes are usually sites of increased growth, either be it a malignancy or be it a benign tumor. This is called video assisted thyroid parathyroidectomy. Okay. You can see a small yellow globule. The upper one is the thyroid gland. This is the thyroid gland. Okay, this is the inferior thyroid artery. I'm sorry. This is the recurrent, as is interpreted bishop. This is the recurrent lamellar, and above it is the parathyroid gland, parathyroid adenoma. This is the parathyroid gland. This is the parathyroid adenoma. And coming to the complications, like any surgery, there will be hematoma formation, and there will be wound infections. And the most common complications is a hypoparathyroidism, because I have removed all the glands, and the patient will complain of symptoms of hypocalcemia. Coming to the symptoms of hypocalcemia, the first symptom is perioral numbness. Perioral numbness, followed by what is called twitching of the mouth when you apply when you flick your finger on the zygoma bone. You will twitch the mouth. You will twitch the mouth, and there is something called coastic sign. Coastic sign is nothing but and there will be coastic sign, and the patient will complain of tetany. The patient will complain of tetany. Tetany is nothing but spasmodic contraction of the muscles. Tetany is spasmodic contraction of the muscle. So okay, again to summarize, the patient will initially complain of perioral numbness, and these symptoms will manifest 24 hours after surgery. The body calcium is sufficient for the first 24 hours after removal of parathyroids, and so the symptoms will start 24 to 48 hours after surgery, and the patient will complain of perioral numbness, the first sign. And to elicit the hypocalcemia, if you flick your finger on the zygomatic process, on the zygomatic one, the patient will twitch the mouth, because you are stimulating by flicking the finger, you are stimulating the facial nerve, and because of hypocalcemia, it will be in hyperexcitable state, and the patient will twitch the mouth. And this sign is coastic sign. And there is something called a tourniquet sign. Tourniquet sign, where you apply tourniquet BP apparatus to the hand, and you apply pressure. The patient will this hand will go into immediate tetany. The hand will go into immediate tetany. Tetany is nothing but you squeeze your hands. You squeeze off your hands and stay in that position. Okay, these are the post-op complications, and these are the post-op complications. And in surgical point of view, the hyperparathyroidism is only important, and hypoparathyroidism is important in the medical stand of view. It is not much dealt in surgery, but hypoparathyroidism is a complication, is or may be a complication of surgery. As I told you, it may or may be a complication of total parathyroidectomy, and is a complication of total parathyroidectomy, and then total thymectomy. These are the various features of hypoparathyroidism. There will be less calcium in the body. Excess calcium is a problem. Less calcium is also a problem. And the body will have less calcium. There will be dental problems, bony problems, muscular problems, neurological problems, and so on. Okay, and this is the comparison between the various symptoms. Okay, this hyperparathyroidism will be dealt with in the medical chapters. Okay. Okay, this is the class for today. This is about parathyroid glands. Anyone got any doubts? Shall we conclude the class?